button.
I'm Jerry Hesch at the Hesch Institute in Aurora, Colorado. I'm an orthopedic manual physical therapist, and I have a 78-year-old contractor who was injured in a severe motor vehicle accident in the year 2010. And I'm going to describe the areas in his body where motion has been lost. The first thing that I find is in both ankles, the foot only comes up to neutral, okay? 0 degrees of dorsiflexion. I might be able to increase that on both sides, I'm not sure. But he definitely has some symptoms on the outside, the lateral part of his lower leg. And what I find is that his fibula is stuck inferiorly, with the lateral malleolus being forward and the fibular head being backwards, and there's no passive motion available in that joint. On the left side he has normal mobility. Okay? And then when it comes to his pelvis is twisted to the left. He has blocked posterior rotation on the right. We name that a right anterior ilium. It actually involves the whole pelvis being twisted. Maybe it blocks motion in the SI, maybe not. You know, no one's done the research on that pattern, but I describe it as a whole pelvic pattern. He has more going on with the pelvis. And what he presents with is the coccyx is stuck in left side bending. Okay, so the bottom of it points out to the left. The right ischium, if you look at the midline of the crease of the buttocks, the right ischium is closer to it by about, when I palpated, it's about 2 thumb widths, whereas the left ischium is at least 3 thumb widths lateral. And there's no medial or lateral spring motion available as well. And I'm very confident that that's treatable, that the side bent coccyx is treatable. He also has some neuropathy of the anterior lateral femoral cutaneous nerve, also of the ilioinguinal and genitofemoral nerve. And the question is, if we remove this twisting pattern in the pelvis, will that take pressure off those nerves and allow them to heal over time? And that's an unknown. We can only find out by trying. Okay? The other patterns that I find in his body, he has shoulder pathology on both sides, partial tear of the supraspinatus tendon on both sides, fluid collection in the bursa of both shoulders. He's got arthritic changes in the acromioclavicular joint, impinging in the shoulder space, impinging on the supraspinatus tendon. What I find with his shoulders, he does have about 120 degrees of flexion. He gets pain at 90 degrees of abduction. Okay? What I find is that his acromioclavicular joint, where the clavicle joins the scapula, the top of the scapula, this little projection is called the acromion. So here's the clavicle, and that forms the acromioclavicular joint. It appears that his scapula are compressed anterior medially. Okay, that joint is very compressed. I get no spring motion through his shoulders. The other thing connected to that, he had an injury to his first rib, as evidenced by the fact that the first rib at the costochondral joint in the front has an 11 millimeter osteophyte. Okay, and when I try and get some anterior spring mobility of that first rib, it doesn't move. Whereas on the right side, the first rib has good spring mobility. The other thing that he presents with is some degenerative changes in his neck. Backing it up a little bit, he gets swelling in his wrists. Okay, he's had a workup, and they don't they're not really sure if it's carpal tunnel syndrome or not. Seems to be more of a thoracic outlet syndrome. So the question is, if I increase scapular and acromial clavicular mobility, open up some space in that thoracic outlet, can we reduce swelling in his wrist? It's an unknown, but I am certainly going to try, and I'm going to lean on those, on the acromion on both sides, pushing them posterolaterally for 5 minutes and see what we can gain. He gets some radicular symptoms down the left arm, correct? Okay, yes. Do you get any down the right arm? No. Okay, very good. So it begs the question of, if we open up the thoracic outlet and if we increase rib mobility, we're going to take pressure, we're going to relax the scalenes. Maybe even relaxing the scalene muscles will reduce pressure on the blood supply and even on the innervation of the brachial plexus, the nerve to the arm. Remains to be seen. We'll find out. Okay? His neck, when he lays on the table, is in hyperextension. Okay? And when I try and spring the mastoid process in rotation, I get a little bit of spring, I get a little bit of side bending. So his OA joint has mobility, okay? But when I come off the mastoid, I quickly hit the transverse process of C1, also named the atlas. And that happens when the atlas is in hyperextension. Okay? And when I traction the joint of the atlas and axis, the C1, C2 joint, the way that that's done is by contacting in front of the joint. Those two joints are in the front of the neck. Okay, right here and here. Whereas the other facet joints are in the back of the neck. So when you traction the mid joints, you bend the head forward and you contact the occiput. But when you want to isolate either the OA joint or the atlantoaxial joint, you have to have a force that's in front of the mastoid. And so my contact is going to be on this part of the head in order to test traction. And when I test him just laying there, there's no motion. I put his head in extension, drop the head of the table down, there's no motion. I bring him up to about 10 degrees of neck flexion, no motion. And then when I get him a little bit higher, like 20 degrees of neck flexion, then we get a little bit of neck motion. Okay? So I'm going to demonstrate these movements on him. I will add that next year I have a chapter coming out February 2020 on treating the atlantoaxial joint for this type of extension, compression, dysfunction. And it's very different from the lateral treatment that you find all over the internet, all over YouTube. Almost, every video is on treating rotation of the atlas. This is about treating flexion and distraction of the atlas, dropping the front of that. It's a round joint. It's a round vertebrae like a donut, and it's about dropping it down in front. It sits on a peg. It connects to a peg called the dens from the second vertebrae. And my treatment is to traction the back of it and drop the front of the donut down on the peg. So anyway, don't want to go into a lot of detail there. What I will do is show you his presentation. I'll have him lie on the table. I'm not going to show treatment technique here, but I have other YouTube videos. If you're interested in upper cervical, then just type in my last name, upper cervical. Just put Jerry Hesch, last name H-E-S, like Sam, C-H, and then just type atlantoaxial joint or upper cervical or foot and ankle or anterior ilium or lower windswept pelvis or first rib or AC joint, also called acromioclavicular joint, and you'll see some treatment techniques there, but I'm not going to cover that today. So let's go ahead and have you lay on the table, okay? And I think we'll make that part 2 video. So go ahead and stop filming.